All right, guys. Excited for today's session. I think after the last three sessions that we've had, this is kind of what a lot of this has been building towards to um, really start with screening and epidemiology and gain some comfort with interpreting serologies, and now to kind of take a dive into how we manage patients with Hep B infection and talk a little bit about new and emerging therapies and how this fits into how we manage patients. All right, so let's talk a little bit about our case. So this is UN. This is a case for those of you who are new. We've been kind of evolving this case over the series. So this is UN. She's a 28-year-old woman who was born in the United States. Her parents were born in Taiwan and moved to the United States 2 years before UN was born here. UN was screened for hepatitis B by her primary care doctor. These are the screening test results. So she was surface antigen positive, and she was negative for surface antibody and core antibody. So we know that she has chronic Hep B infection based on this. And so this prompted additional serologies. I guess to be confident that this was not acute infection, we also checked core IgM antibody, which came back negative. So this was not likely consistent, especially given her family history, particularly her parents being born in a high endemic surface antigen prevalence area of the world. The additional serologies that were checked included her E antigen status. She was E antigen positive. She was E antibody negative. We also checked Hep B DNA viral load. So this was 454,000 international units. And her ALT came back with a value of 12 for liver enzyme test. So the question is, now what? So tuck that in the back of your mind as we start to move through this talk. So I think one of the areas we like to always kind of start with is just really reiterating that we have a highly effective way to prevent hepatitis B through a vaccine. And the vaccines, there are several different kinds that are available for adults, either as 2-dose and 3-dose. A combination of Hep A and B vaccine is also available. That's given as still the 3 doses. HCC is the first vaccine preventable cancer. Remember, Hep B causes liver cancer or hepatocellular carcinoma, HCC, and actually accounts for the most number of cases of liver cancer worldwide. And so by preventing Hep B infection through a highly effective vaccine, the vaccine actually prevents liver cancer. So it's the first vaccine preventable cancer. So keep that in mind. So the other thing to kind of start out with is once you're at the stage where you've done screening and you've identified somebody who as being surface antigen positive or having Hep B infection, this is where you're kind of at a crossroads to either think about referring to a specialist or taking this on and managing it from a primary care standpoint. And a lot of this is really based on your practice characteristics, where you practice in the world, access to specialists. And it's really important just to understand that anybody with Hep B infection needs to be managed for Hep B. Really, there's no role in a surface antigen positive patient to not be doing anything with these patients. And so this is a chronic disease, just like we manage hypertension and diabetes, and really needs to either be managed by specialists or it can be managed effectively in a primary care setting as well. Now, Hep B treatment should be considered in various categories of people, and that's what we're going to actually be spending quite a bit of time on. And most of what we cover is going to actually be based on the US based American Association for Study of Liver Disease guidelines. But because we have a number of our participants who are international, we've actually added some information about the European guidelines, which I believe are what are used in particularly West Africa. But please, correct me if I'm wrong. And patients who are not on treatment should be monitored regularly with blood work every 3 to 6 months. And we'll talk also at the end of the session about liver cancer screening and who you should be screening. But this screening should be done every 6 months if criteria are met, with or without alpha-fetoprotein, a blood serum marker. All right, so what are the goals of Hep B therapy? Number one, to improve survival and quality of life, to prevent disease progression or reduce the risk of disease progression, and prevent liver cancer or reduce the risk of liver cancer. Prevent mother-to-child transmission. So in the next session, the last session, we're going to talk about various patient populations, including pregnant women. Prevent Hep B reactivation, particularly in the setting of immunosuppressive therapy for cancers or other chronic diseases, which will also be covered in the next session. Prevent and treat Hep B associated extrahepatic manifestations. These are quite rare, but by treating Hep B, we can also treat things that Hep B can be associated with outside of the liver. The goal of therapy is really to have long-term suppression of Hep B DNA viral load, normalization of your liver enzyme ALT test, and really to look to see if patients lose e antigen, or what we call seroconvert. So they lose the e antigen and gain the e antibody. And really the best, most ideal thing in a therapy that we're still not very successful at doing with our available treatments is inducing surface antigen loss or curing patients, which is also referred to seroconversion. So kind of generally, who should we be treating? So decisions really around treatment are made based on your Hep B viral load, your ALT, your degree of liver disease or fibrosis. And we'll talk about how these all kind of go together, and risk of complications. Generally speaking, you should be thinking about treatment in anybody who's got a detectable Hep B DNA level or virus present who has cirrhosis or liver cancer. So all of those patients, irrespective of their e antigen status and the level of DNA, should be treated. And then what we're going to spend some more time talking about on the next couple of slides is what to do in e antigen positive and e antigen negative patients, and the thresholds as it relates to Hep B DNA for treatment. The general things to keep in mind is that in an e antigen positive patient with the viral load over 20,000, you should be thinking about whether or not you should initiate treatment. And in somebody who's e antigen negative, the threshold is lower, because remember, these patients tend to be in a later phase, if you will, of having had this virus for a longer period of time, and are more likely to be in that chronic hepatitis or progressive fibrosis phase. So the threshold's lower with the DNA level. But I'm going to tell you on the next couple of slides how ALT level and fibrosis assessment can help with these decisions and make this a little bit more nuanced. And then you want to consider treating anybody who's got evidence of advanced fibrosis. So fibrosis is typically measured on most scales from 0 to 4, but there are some scales that go 0 to 6. So anybody on that 0 to 4 scale, that's 2, 3, or 4, or on the 0 to 6, 3, 4, 5, or 6. So anybody with what we call advanced fibrosis, anybody with really a first-degree relative, a family history of liver cancer, anybody with extrahepatic manifestations, and then folks who might fall into the immune tolerant category, and we'll break that down. So again, these are based on the American Association for the Study of Liver Diseases. There are separate guidelines for the European groups. There are separate guidelines for the Asian Pacific American. My understanding is that much of the African nations use the European guidelines, but happy to discuss this further based on the providers who are joining us from that region at the end. So we're going to start out with the American Association guidelines, and many of these are very similar. There are a lot of overlap, and you'll see that. So this is for anybody who has chronic infection, so they're surface antigen positive, and they're e antigen positive, okay? So there's a little asterisk down here at the bottom that's very helpful. The true, what we call upper limit of normal of an ALT for a man is roughly speaking 35 units per liter, and in women, females, it's 25 units per liter. Now, each individual assay that you might use in your clinical practice might vary a bit. For example, the assay that I use at my work, the upper limit of normal on that assay is determined by the folks who run and make that test is 45. But what's truly considered a normal value is usually much lower than the threshold in the laboratory values through the commercially available lab systems. So we use 35 and 25, 35 for men, 25 for women as the upper limit of normal here. This is based on data that in healthy adults, the range for men is 29 to 33, and in women 19 to 25. Okay, so they really picked kind of a higher end cutoff, if you will. All right, so we talked about on the prior slide that e-antigen positive patients who have a Hep B DNA viral load that's over 20,000 may be considered depending on what the ALT value is. So if the ALT value is normal, these patients fall into this blue category here of do not treat at this time, but rather monitor them with ALT and Hep B DNA levels every 3 to 6 months and repeating the e antigen every 6 to 12 months to see if they change over time. In those patients who are e-antigen positive and the Hep B DNA is over 20,000 and the ALT is somewhere between the upper limit of normal, so upper limit of these threshold cutoffs, but less than 2 times the upper limit of normal, so less than 70 in men and less than 50 in women. These are patients who may represent being in the seroconversion phase of losing e-antigen and developing e-antibody over time. So typically we recommend to monitor a little bit more frequently for the first year, and then if things are pretty steady, then you can consider monitoring every 6 months and consider treating in these people. So the gray references to the gray box down here. So it's very important in these patients with a raised ALT that we've excluded any other cause of liver disease. So make sure that you've done your Hep C testing in these patients, taken a really good alcohol history to be confident that we're not missing anything else that's contributing to liver inflammation or liver disease. And then there are a number of ways to assess the severity of liver disease as measured by fibrosis using non-invasive tests and or liver biopsy. So, you know, when I was first training, we didn't have a lot of these non-invasive markers very well developed or available. And so liver biopsy was what we were always at the crossroads of considering doing for patients periodically. In my practice, because of the availability of some of these non-invasive markers such as of transient elastography or other measurements, we don't do liver biopsy as commonly in my practice. So if you use one of these non-invasive tests or a liver biopsy, what you're trying to determine is how much severe necroinflammation as measured by the A scoring or fibrosis there is. So as I mentioned, most fibrosis is measured now on a 0 to 4 scale. So if that's greater than or equal to 2, or if your inflammatory score is very significant, greater than 3, usually goes up to 6 or 8 in some cases. These are people that you want to have a really good understanding that they have more advanced disease likely. And if other causes of the ALT being above the upper limit are excluded and the ALT is persistently elevated, it's recommended you move them into the purple box of treatment, especially if they're over the age of 40. And then finally, this last category is people who are e-antigen positive and who have an ALT that's more impressively elevated. So greater than or equal to 70 in men, greater than or equal to 50 in women who have a Hep B DNA greater than 20,000. This automatically kind of moves somebody into a treat now category in terms of recommendation, because these people are at highest risk for more progressive liver disease or fibrosis and or liver cancer. And if your Hep B DNA is between 2,000 and 20,000 in the setting of your ALT being greater than 2 times the upper limit of normal, this also may represent seroconversion with E antigen loss and gaining E antibody. So you can monitor them, and if it persists for more than 6 months in terms of the ALT elevation, you should consider treating those folks. All right, that goes over kind of the E antigen positive patients. Then we have the category of patients who are E antigen negative. So UN in our case at the beginning was E antigen positive, just to keep that in the back of your mind. And so here we have E antigen negative status patients. So if the ALT is within a normal range, again, the normal here is defined as less than 35, less than or equal to 35 in men and less than or equal to 25 in women, and your Hep B DNA is greater than or equal to 2,000, these are people who can be monitored with ALT and Hep B DNA every 3 months for 1 year, and then every month. If the ALT becomes elevated, it's important to exclude other causes of the ALT elevation, take a good alcohol history, if appropriate, retest them for Hep C, and assess liver disease severity with non-invasive ways to see if fibrosis has shifted from maybe the first time you started following the patient and now. And if the staging indicates, again, more advanced fibrosis, F2 or greater, or very severe necroinflammation, those are patients who should be considered for treatment. And then persistently elevated ALT above the upper limit of normal with the Hep B DNA greater than or equal to 2,000, really consider treating those, especially if the age is greater than 40. In those patients where the Hep B DNA is less than 2,000, those patients and who have a normal ALT can be considered with just kind of watchful waiting and monitoring their ALT and Hep B DNA levels every 3 to 6 months to see if anything shifts. Now, in those patients who are E antigen negative, but the ALT is above the upper limit of normal, but not quite 2 times the upper limit of normal, these patients fall into a monitoring category as described previously. And those who have an ALT level greater than 2 times the upper limit of normal who are E antigen negative, again, if the Hep B DNA is greater than or equal to 2,000 units, this is highly suggestive that these patients have more progressive fibrosis or are at risk for more progressive fibrosis and liver cancer, and therefore fall into a treat now category. This is different than those who have maybe an ALT that is greater than 2 times the upper limit of normal, but the Hep B DNA is less than 2,000. The only exceptions to any of this is if somebody has cirrhosis, in terms of their fibrosis scarring, and all of those patients should be treated now. Okay, so one question that comes up quite often is, why not treat everybody? Well, we mentioned in the very first session in terms of the scope and the epidemiology and burden of infection from a public health standpoint, close to 260 million persons worldwide have Hep B infection. Most of this acquired at birth. And treatment right now is lifelong. We'll talk a little bit about the new and emerging therapies that are looking at developing curative therapies, but they're not yet available for clinical practice. And so theoretically, yes, it could be an idea. We also know that based on that first session, the information I went over, less than 50% of people develop progressive fibrosis over time, and not everybody will develop liver cancer. We don't have the tools in our toolbox yet to determine who's at risk to develop right off the bat liver cancer and progressive fibrosis. We may have some more markers or indicators that would help us select some more patients for therapy. But so we wouldn't commit everybody to lifelong therapy, particularly those who get it at birth. It just is not a cost-effective, really, strategy. Now, there are limitations of current therapies. Current therapies suppress infection. They do not eradicate a infection. These newer therapies that are under development are looking to try to eradicate or cure people of infection. So it really means that once we start treatment, it's lifelong and it's long-term. And really, treatment decisions are very much individualized, even within those guidances. Our job is to really inform and counsel patients about what their risks are for not initiating treatment if they meet guidances, but like with anything else, there'll be some patients in your practice who accept treatment, some who may not have access to treatment, some who do not want treatment. But once started, it's considered lifelong and long-term, and it's very important that once treatment is started, it's not stopped, because that can create a flare in some patients. And then there are implications for drug resistance. And this is not so much an issue with our first-line therapies, but in some of our older antiviral therapies, this was a big issue. So timing of when you initiated treatment it needs to be very thought out. All right, so if you have a patient who falls into one of those do not treat now monitoring categories, it's important to know how to monitor them and how often. So in e-antigen positive patients who have chronic infection, so the people on the first algorithm slide who are less than 30, who don't meet routine treatment criteria, you want to follow these patients every 3 to 6 months in your practice. And the typical tests you're going to check at each visit includes at least an ALT every 3 to 6 months, a Hep B DNA level every 6 to 12 months, and you want to reassess liver fibrosis typically every year if possible using non-invasive markers. We typically try to avoid doing biopsies that frequently on patients. If biopsy is the only fibrosis assessment test, you usually may do it every 2 to 5 years in somebody who has signs of that may put them at higher risk to develop fibrosis over time. And then it's important to not forget about the category of people who are going to fall into liver cancer screening, which I'll talk about towards the end. In those patients who are e-antigen negative with chronic infection, the Hep B DNA threshold of less than 2,000 and don't meet any other routine treatment criteria, you can follow these patients every 3 to 6 months. Again, checking the typical tests here on the right. And in those who are e-antigen negative, who have a Hep B DNA greater than or equal to 2,000, who don't meet routine criteria based on your fibrosis assessment or ALT, you can follow these patients every 3 months for a year. And if there's not significant changes with their ALT, then move them out to every 6 months in terms of your monitoring strategy. All right, so we've talked a little bit about kind of the algorithm, and that's a good, those 2 slides about the algorithm of e-antigen positive and e-antigen negative are good ones to refer back to try to keep, keep in mind who you should be considering treatment now and who can wait. We talked a little bit about the patients who don't meet treatment now, but in terms of how they should be monitored over time. So now let's kind of move a little bit more towards a discussion of treatment itself. So there are a number of drugs with anti-hepatitis B antiviral activity. The ones highlighted in green here are really what we consider our first-line therapies for hepatitis B. I would like to hear towards the end of the talk, particularly in our international participants, the availability of some of these treatments in your settings. So entecavir or Baraclude, tenofovir or Viriad, the new formulation, tenofovir alafenamide, which is a prodrug of tenofovir, also called Vemlidy is the brand name, and then pegylated interferon alpha or Pegasus, which we'll talk a little bit about, which isn't used that much in clinical practice. This is the one treatment that can be considered a finite duration of treatment, but it isn't used because it's an injection treatment in most patients. It's not prescribed because of the convenience and ease of taking it and monitoring. Okay, and the drugs highlighted with an orange asterisk, including some of our older drugs such as lamivudine and tricytabine, and the newer drugs such as tenofovir and Taff also have activity against HIV. So it's really important as part of your pre-treatment evaluation, you are confident in the HIV status of your patient, and if they do have HIV, it's important that you are managing the HIV in addition to the Hep B, and Hep B therapy should never be started as monotherapy in somebody with HIV who's not on treatment, because that can lead to big time resistance issues and problems with HIV therapy down the road. Okay, so the drugs that are really considered a first-line treatment are really those that have the lowest rate of resistance. Okay, so tenofovir and entecavir, and we can actually add Taff here as well, since that's the prodrug of tenofovir. So resistance reporting is at 0% to 1.2% in these therapies. As you move in the spectrum of other antiviral therapies, and these are all pill-based therapies that we have listed on the slide here. Interferon's the only injection-based non-pill therapy. Entecavir also has resistance rates that increase over time, and the drugs that are really considered third-line therapy have the highest rates of resistance. So we found that, really up until about 10 years ago or so, entecavir and lamivudine were really the mainstays of treatment, but over time what we realized is that a good proportion of patients developed resistance over time. So we think about our treatment options as being our kind of pill-based nucleotide or nucleosides. The pros here are oral administration. They are one pill once a day. They are typically, for the most part, as a group, well tolerated. They do have some minor side effects, and they are pretty effective at maintaining the goal of treatment response, which is Hep B viral load suppression. The cons, depending on really the line of therapy, so is resistance, which we don't see as much of with our first line therapies. So this was really more of an issue with our second and third line therapies, which used to be the mainstay of treatment, up until about a decade ago. The duration is somewhat discussed and a little bit controversial depending on whether or not you have zero conversion of E antigen on therapy and loss of surface antigen over time, which is a pretty uncommon phenomena on treatment. And then long-term safety, given the newness of a lot of these first-line therapies, is being studied actively. Looks like they're pretty safe, but we don't have, for example, 40 years of data on some of these newer drugs. Pegylated interferon is an injection-based treatment, so patients actually have to give themselves an injection. It's a subcutaneous injection, similar to what diabetics have to do with insulin. The pros is treatment for a finite duration, so the treatment is given for about 24 to 48 weeks. You can follow them after you've complete treatment for sustained response. What we found for most patients over time, sometimes on the order of months or years, is that oftentimes they're at high risk for virus to come back. So they do, even after finite duration of therapy, need to be monitored very closely to see if they long-term kind of fail therapy. There doesn't appear to be any obvious resistance. The cons here, it's an injection. Side effects are a little bit more pronounced and contraindicated in some certain groups of patients, including pregnant women, cirrhotics, and patients post-transplant. So I'm going to show you here, just kind of gives you an example of what you see with respect to Hep B DNA levels and Hep B surface antigen with pegylated interferon. So you see with therapy, pre-treatment, the levels are kind of at baseline. You'll see a pretty marked decline with both Hep B DNA and surface antigen with pegylated interferon that tends to come back up off of treatment, so 6 months post-treatment. Even if you add antiviral therapy such as lamivudine, you'll see similar responses over time. And with lamivudine, we know that the Hep B DNA here comes down, surface antigen titers don't decline as robustly. So I'm going to move through some of these slides so we get through everything, and then we can open it up to discussion. If you this is a nice table kind of looking at the efficacy of current therapies in E antigen positive patients, and on the next slide I'll show you the E antigen negative patients. So the dose of various therapies, pegylated interferon alpha 2A, alpha 2B is a little bit different. When you look at rates of E antigen seroconversion, you actually have quite high rates, but this can then return 1 to 2 years off of treatment. Hep B DNA levels being less than 60 to 80 are not always achieved as robustly as some of these newer antiviral therapies. We were comparing it to LAM on the last slide, lamivudine, an older third-line antiviral therapy. If you look at ALT normalization on treatment, we see more robust responses with respect to kind of all of these parameters with our newest first-line treatments of tenofovir and tenofovir alafenamide. And then the trade-off here is surface antigen loss is actually much higher in patients treated with pegylated interferon. So it's a bit lower with the newer treatments, but not really much different than some of our older antiviral therapies that are now second and third line. So for e-antigen negative patients, you also see kind of most favorable profiles with respect to Hep B DNA suppression and ALT normalization with tenofovir and Taff. And you don't really see much surface antigen loss in these patients. So it's really your e-antigen positive patients that you might be hopeful of seeing this at a very, very, very low rate over time. You do have an increased result of surface antigen loss in patients treated with pegylated interferon. All right, so what is the difference between selecting entecavir or Taff over tenofovir? So, you know, when is tenofovir or TDF less preferable? So certainly in patients over the age of 60, and this is in large part due to the fact that they're at higher risk for bone disease and kidney disease, two other side effects that we see with tenofovir treatment. So tenofovir also puts patients at a little bit higher risk for osteoporosis or bone disease, particularly in patients who have chronic steroid use or use of other medications that might also worsen bone density over time, and certainly in people with a history of any fragility fractures. And then finally, tenofovir also has been shown to lower your GFR over time and also lead to increased loss of albumin in the urine. And so it's really not recommended for patients with significant kidney disease at baseline or bone disease or persons over the age of 60. When we're talking about initiation of therapy on patients, so you start with a patient with chronic Hep B infection who meets your criteria for treatment, as we've discussed about in the slides previously. And what you're really trying to achieve with treatment, as I mentioned, is viral suppression, so viral control. None of the treatments that I just discussed really lead us to a cure or complete eradication of the virus. So viral suppression is what we are aiming for. And in these patients, even if you have steatosis, obesity, and diabetes, we know that fibrosis progression is less likely, and you're actually likely to have regression, which can also help lower your risk of liver cancer. Now, in patients who are not treated, who have also other metabolic risk factors that we quite commonly see in practice, right? With the rising epidemic of obesity, having fatty liver, concomitant diabetes, these patients are particularly high risk to develop cirrhosis or advanced fibrosis and liver cancer over time. So treatment with viral control can really take us into the other direction of fibrosis regression and reduce our risk of cirrhosis and liver cancer compared to those who have infection who meet criteria, who might have other concomitant factors that also accelerate this disease progression. So monitoring during therapy recommendations, ALT and serum Hep B DNA on all patients treated with nucleoside or nucleotide analogs. You want to also consider kidney monitoring, renal monitoring through at least a GFR and serum phosphate level in patients at risk of renal disease treated with any, but particularly in those treated with tenofovir. So we typically screen all our patients at baseline to check their urine dipstick and their GFR and serum phosphate levels before making decisions about treatment, and then on treatment with tenofovir. And then in terms of recommendations long-term, it's important to think about who might be at risk for liver cancer and and also think about all patients with cirrhosis or moderate or high HCC risk scores at the onset of nucleoside analog therapy to be considered for screening. When can you stop therapy? Generally speaking, you don't and you should not. It's required really to be lifelong or indefinite therapy until newer therapies that get at a cure are available. Nucleoside or nucleotide analogs should be discontinued or can be discontinued after confirming surface antigen loss, which again happens at 0% of the cases on these treatments in E antigen negative patients, and at best 1 to 3% of E antigen positive patients. And these patients will also have may or may not have development of surface antibody, which is a favorable profile. Nucleoside and tide analogs can be discontinued in E antigen positive patients without cirrhosis who achieve E antigen seroconversion and undetectable Hep B DNA after they complete 12 months of consolidation therapy, but close post antiviral treatment monitoring is warranted. So typically you have these patients come back every 3 to 6 months the first year, and then every 6 months thereafter to monitor to make sure they don't develop E antigen again and detectable viral load. And treatment may be discontinued in selected E antigen negative patients without cirrhosis. We hardly ever do this because of the risk of Hep B coming back is very high. And they have to achieve long-term virological suppression with Hep B DNA that means more than or equal to 3 years. And they also need close treatment off therapy. And that needs to be done, so you only want to do that in a very reliable person who's committed to post-treatment follow-up. All right, so this kind of talks about the various terms we sometimes use. So somebody who doesn't have much of a drop, less than a 1 log drop in Hep B DNA is considered a primary non-responder to antiviral therapy. Somebody whose Hep B DNA viral load goes down and then comes back up, after being suppressed by greater than 1 log of the Hep B DNA level is considered breakthrough. Partial response is somebody here seen in light blue who the DNA level comes down but never gets down to really the bottom here. So they have more than a 1 log drop in their Hep B DNA level, but it's still detectable on therapy. And then somebody who has a response is really what you're looking for in this pink here. So somebody whose Hep B DNA level becomes really undetectable over time. Now, I mentioned a little bit about resistance. This talks about the various therapies available. You'll see lamivudine and adefovir. Lamivudine are third-line therapy, adefovir are second-line therapy, and entecavir, tenofovir, and Taff. You can see the marked difference with the longer you treat a person with lamivudine, very high rates, 70% develop resistance at the 5-year mark, and with adefovir, close to a third of patients develop a resistance. Entecavir has also had reportedly very, very low rates of resistance of as high as 1.2%, and there's been no reported resistance with tenofovir Taff in the studies that are going out now 7 and 8 years. If you do send somebody for resistance testing, it's usually sometimes done in conjunction with the Hep B genotype or just as a separate Hep B resistance panel testing, depending on the lab you're using. This just shows you in different colors. R stands for resistance, S for sensitive, and the various types of mutations that you can see or points that you can have resistance towards. How you take that data and synthesize it is that if you have resistance, for example, specific to lamivudine, this would then lead you to switch over to tenofovir or Taff. Remember, lamivudine is not really used much in clinical practice because it's now considered a third-line agent. For those on telbuvudine, you can switch to tenofovir or Taff. Entecavir resistance, you switch to tenofovir or Taff. There has been no reported tenofovir or Taff resistance, but that you could consider either adding entecavir if somebody's LAM resistance, or in somebody who's never seen lamivudine, switch them over to entecavir. And then it talks a little bit about multi-drug resistance, which I don't think you're very commonly going to see, but there is basically a switch or add-on strategy for anybody who does develop resistance on treatment. So as we near kind of towards the end of our slides here, this is kind of a nice summary slide. So if you have somebody who's suspected of Hep B or at risk for Hep B infection, you screen them for surface antigen. If they're surface antigen positive, they have likely chronic infection. So you go down the pathway of checking additional tests, depending on what those tests show, including the DNA level, the ALT, and your fibrosis assessment and their E antigen status. That tells us who should be considered for starting antiviral treatment versus who can just be monitored. And then you want to consider risk of HCC, risk of reactivation, which we'll talk about in the next session, and the risk of transmission too in the context. In those who screen negative, they don't need any follow-up, but it's important to understand about the potential in somebody who's core antibody positive for the risk of reactivation, which we'll talk about in the next session next week. And you might start antiviral prophylaxis in the setting of immunosuppression on some of those patients, which we'll discuss in detail. All right, so we're going to circle back to our case here. UN, so she's got chronic Hep B infection. She's E antigen positive. Her viral load's very elevated, but her ALT is 44. So 44, we can actually open this up to a little bit of discussion before I finish up with our slides. Anybody have any thoughts on where she would fall? Treat now, monitor, does not need treatment? We have any volunteers?
Treat her, you know, her ALT is 44. The upper limit of normal is 25. So,
yep, and her Hep B DNA is greater than, is high.
Yeah, she's E positive. And particularly if she has family history and so on, I would rather treat her. And her age is also 28. This is against. So there are a number of points forward and against. But in any case, I would opt to treat her.
Okay. And again, I think that would be reasonable. As you're just pointing out, a lot of times this is very much individualized to all of the different factors that might be going on with the patient, what a patient's comfort level is with treatment. Some patients say, no way, I don't want treatment unless, you know, it's the end of the road and there's nothing else I have left to do. Some patients might say, oh gosh, I want to do anything I can to really reduce my risk of progression or reduce my risk of cancer, even if I don't meet all the guidelines for treatment. And then there may be some patients in between where we talk about what all of these other things play in. But her age being less than 40 might be kind of leaning you against. She kind of falls into the greater than upper limit of normal, but less than 2 times the upper limit of normal category, but she's E antigen positive and her viral load's high. So I think you could reasonably go with either potentially a monitoring or treatment strategy for this patient. But if the ALT was persistently elevated, she would probably fall into a treatment category. Any other thoughts?
I saw a raised hand from Patience. Patience, did you want to comment?
Hi, good evening, everyone.
Hi, Patience.
Yeah, I think for her, I'll still go ahead if facilities are available to assess her liver status. Maybe have a fibro scan done for her, or maybe calculate her pre-score. And then depending on that, it could warrant treatment. She may warrant treatment. So if she has a fibro scan getting into probably advanced fibrosis or even a moderate fibrosis, I would consider treatment together with what has already been said.
So that's a good point. If you go back on the slide, she would fall into that fibrosis assessment category. And if she's F2 or higher, she would definitely probably lean you towards considering treatment. Her age being less than 40 by itself isn't a factor that would trigger that, but I agree. Doing a fibrosis assessment can really be helpful here. And again, depending on where you practice and what the availability of different tests are, you know, I think we've moved a little bit more away from just using ALT to now really needing the fibrosis assessment as well. Very great. That's a great discussion. Any other comments or points? Okay. So who should be monitored for liver cancer? So let's kind of try to wrap up here on these slides. So somebody who's non-cirrhotic for Hep B, we remember Hep B by itself, even independent of fibrosis, unlike any of the other liver diseases that we have, is an independent risk factor for liver cancer. Hep B itself is oncogenic, causes cancer, and liver-related likely related to, DNA integration into the host genome, that covalently closed cccDNA. It may put us at higher risk for cancer in these patients, and that the threshold for screening in Hep B without cirrhosis occurs when we think the annual risk or incidence of cancer, is greater than or equal to 2.2%. And the other things that go into determining who should be screened for liver cancer is the cost effectiveness relative to life years gained. So these are some of the things that have been kept in mind in developing guidances for liver cancer screening. So the AASLD guidelines for liver cancer screening in a non-cirrhotic Hep B infected person include patients with cirrhosis, so that's not really non-cirrhotic, but certainly if somebody has cirrhosis, they meet a category of liver cancer screening. And anybody without cirrhosis who's Asian or a Black man, so Asian or Black men over the age of 40, and Asian women over the age of 50 are recommended for liver cancer screening lifelong. Anybody who has a first-degree relative with liver cancer who's got Hep B infection should be screened for liver cancer. So if you have a patient like UN, let's say her mother or father or a sibling, brother or sister had liver cancer, that would automatically put her in a category for liver cancer screening. And then anybody over the age of 40 with persistent or intermittent ALT elevation and or that high Hep B DNA level. Screening is recommended to be performed with ultrasound examination with or without alpha-fetoprotein, a blood test serum marker, every 6 months. The caveat here is for people who are living in areas where ultrasound is not readily available, screening with AFP every 6 months should be performed. It's not recommended that AFP as first line is used as your only screening test. It really is meant to be an adjunctive thing to ultrasound, but we know that in certain settings, access to ultrasound might be an issue. So the AASLD guidelines surveilling for liver cancer anybody with cirrhosis who has Hep B, they recommend doing screening or surveillance for liver cancer with an ultrasound with or without alpha-fetoprotein every 6 months. And they suggest to not perform screening in patients with cirrhosis with what we call Child-Pugh class C, so very decompensated cirrhosis, where the life expectancy is quite low, less than 6 months typically to a year in these patients, unless they're on the transplant waiting list because of the cost-benefit ratio. And then AASLD recommends diagnostic evaluation of HCC with either a contrast-enhanced CT or MRI because of poor diagnostic characteristics of our ultrasound modality here in the United States. And then this is just some additional technical remarks regarding the optimal modality and contrast agent. Again, this is really for, you do the ultrasound screening. If it picks up something suspicious, then it would trigger doing a contrast enhanced CT or MRI. All right, I think we're almost out of time, we are out of time. So I just wanted to spend really the last couple of slides on touching on some of the newer therapies to just give you a sense of what's on the horizon, where we're going with Hep B, and this is an area of a lot of excitement and development pharmacologically. The new biomarkers we're looking to target include the integrated cccDNA, which integrates into the host DNA, as well as Hep B RNA, and the composite biomarker CR antigen, which is, I think in one of our earlier questions, it's not clinically available. It's used in a research setting right now. And future treatment options are going to target various other parts of the Hep B life cycle, which I'll touch on the next slide. There are several novel direct-acting antivirals and immunotherapeutic agents that are being developed. So they're already in phase 1 and 2 stage of trials. And then looking also at combinations of antivirals with immune modulatory therapy to get at a cure. All right, so really quickly, the new treatments are going to target entry inhibitors, capsid inhibitors, integration of CCC DNA into the host DNA, will interrupt or prevent transcription, look at viral RNA prevention, translation impediment, as well as preventing encapsulation, preventing reverse transcription, and preventing the envelopment process, and then also exiting of the virus from the host cell. These are the drugs that are currently in phase 2 clinical trials. This list is changing every week, every month. So, you know, this will have to be kind of continually updated as we move forward. There are treatments such as the one here, H0731, which is currently recruiting, which is looking at a core protein inhibitor, which inhibits Hep B life cycle at multiple steps, may lead to a functional cure, and that's what they're looking at as the primary outcome, and leads to Hep B RNA and DNA decline. So there may be a potential role to eliminate the CCC DNA. All right, with that, I'm going to end here, open it up to questions really briefly, because I know we're a little bit over time.
I have a
Yes, please, go ahead.
question. By the fact that, you know, comparing tenofovir and Taff, the S antigen loss is higher with tenofovir, you know, 3% versus 1%. I expected the reverse. So what's the explanation?
I don't think we, you know, Taff is a prodrug of tenofovir. I don't think 3% is definitely higher than 1%. They're still exceedingly low. I think we would all agree. You know, your chance is 1 out of 100 or 3 out of 100 to lose surface antigen. I think we'll see how it bears out with even more time and having a lot more people in the real world on Taff therapy. It became commercially available, I think, in November of 2017 here in the United States. I'd be curious to hear, are you using it in Lagos where you practice, or Ethiopia?
Yeah, we don't have Taff, we have tenofovir.
Yeah.
And
do you know if it will be approved anytime in the coming future, near future?
Yeah. Cost is an issue. Cost is an issue.
Yeah. Right now, I think by most commercially available insurances here in the United States and Medicaid and Medicare, it's available to our patients, but certainly for our uninsured patients, we still struggle with antiviral options outside of clinical trials.
Right.
Hello, Dr. Ponni.
Hi, patients.
Yeah, thanks very much for the presentation today, and to the rest of the team too. Thanks very much. I think relatively most of the drugs are available where I practice. Majority of our patients are on TDF. But recently, like 3 months ago, we have a few patients who are migrating to Taff. And once in a while, we order entecavir for our patient. I remember there was a patient we managed, a young boy who had renal impairment too. And he got 0.5 milligram entecavir, and he did quite well on it. He's still on follow-up. But for Pegasus, the very few patients we try it on, most of the time we have to stop because of the side effect. Yeah.
So I didn't take a deep dive into the side effects of interferon. The best context a lot of people have for this is the old days of Hep C treatment. I will say that interferon is much differently tolerated in Hep B infected patients compared to Hep C infected patients, and that it's better tolerated actually. So, but there still are side effects, injection site-related side effects, systemic side effects, with still having muscle aches and fatigue, really being the most predominant things. And you know, in our part of the world here in the United States, people don't really want to take injection-based therapies if they can take a pill instead. Although the trade-off here is finite therapy versus lifelong. So some people do opt for that. But I have to say, I have not started anybody with Hep B on interferon-based therapy outside of trials for years, really.
Yeah. Okay, then my question finally is, what's the role of surface antigen quantification in Hep B treatment? And so, because I realized, haven't finished. I realized there are some patients we see with very low viral load. We don't put them on treatment. We're monitoring their liver functions and doing the fibroscan for them. But I discovered that if we do, because I started doing surface antigen quantification to see whether they will clear the virus. And like a patient I saw today, the surface antigen is actually going up from 300 and something. Went to 1,000, and as of today, it was 4,000 something. I had to start the patient on Vired.
Yeah.
So that's not in the guidelines, but I don't want to wake up one day and see the man come with liver cancer. So I did that today.
Yeah, I think it's a really great question. I don't think we know yet. There's a lot of research being done looking at change in surface antigen titers over time, either by itself and or in addition to things like Hep B RNA levels, other things that might suggest increased risk of loss of surface antigen that might predict who would be better suited to, one therapy over another. Right now, the commercially available test isn't really useful in our clinical practices by itself, but the research is suggesting that people who have low or high surface antigen titers with some of these additional markers that are being studied, particularly Hep B RNA, which is also not a commercially available test, it's just being done in research settings. Those two combined might have some promise in terms of trying to predict who's at higher chance of losing surface antigen on therapy. So I think there's going to be more to come on that, but right now it's not very clinically meaningful by itself.
Okay, thank you.
Yep.
Great. Ponni, we have a few raised hands, and of course I want to be mindful of everybody's time, but so maybe briefly get through one or two of these. Dr. David, I'm going to unmute you here. Do you have a question?
Yes, I have a couple of questions. Thank you very much for the lecture. Very interesting lecture. I just have some questions that I would need clarification. The first question is, if I have a patient with hepatitis B viral infection with non-alcoholic fatty liver disease or NASH, or non-alcoholic steatohepatitis, who doesn't fulfill the criteria for treatment, considering the presence of this comorbidity in the liver, should I just go ahead to treat even when the viral load is low, or do I still follow the criteria strictly? I want to also know what you do in your practice. And the second question is, let me just ask all the questions. The second question is, you talked about treating patients with family history of hepatocellular cancer.
Mm-hmm.
Yeah, at what viral load? Is it, or just any viral load, any cutoff?
So let me start with the second one, just so I don't.
Treating.
Yeah.
And
so, yeah.
Second, okay.
Mm-hmm.
Okay.
Go ahead.
I still have other questions though.
Go ahead.
Yeah, and what of cirrhosis? What of family history of cirrhosis? Is that also important in treating these patients? Do you consider family history of liver cirrhosis important in commencing a patient on treatment, even when they do not fulfill this criteria of therapy that we talked about? Then the last thing is where you cannot monitor the patient, where you are sure you would not be able to monitor the patient. I mean, that's the viral load is not at the level of treatment, or the ALT is not elevated 2 times the upper limit of normal, and the other criteria we talked about. Do you just consider treating the patient, especially in our environment where most of the patients are resource constrained and viral load is quite expensive, not readily available? What would you advise? Should we just go ahead and treat this patient, knowing fully well that we cannot really monitor these patients based on the cause and other issues, and the fact that we have a lot of incidents of hepatocellular cancer in our environment? I'm going to stop here. Thank you.
Okay, so let me start with the questions. We'll start with the order of the last question first, and I might have to have you repeat the first one because I started taking notes after I realized there was more than one question embedded in there. Okay, so let's start with what to do in a resource-limited setting in somebody who may not really meet criteria for treatment now, but there may be some issues with committing to monitoring strategy alone. You know, certainly in that setting, the thing, and I don't practice in this setting, so I'd be happy to learn from some of you that might practice in a more resource-constrained setting than I do. I always worry about initiation of treatment with the therapies we have available now in somebody where I'm worried about whether or not we're going to be able to monitor them. To me, in the setting I practice, the most common scenario I see this in is in somebody who might be uninsured. And I think a lot of this hinges on a couple of things. One, the most important thing is the reliability of this person to still be able to take treatment, we think, lifelong. I think it's a pretty severe thing to start treatment and not be able to continue it lifelong once it's started, and somebody who maybe who's not in the rare category of meeting one of the stopping rules. I see patients who die from stopping treatment, and develop flares and go into fulminant hepatic failure. I think that influences some of my practice. But really, you want to start treatment in somebody who you think is going to be able to the best of your assessment at that time, which is never 100%, be able to confidently continue treatment lifelong. And so if you're having problems with whether or not the person can commit to monitoring because of financial reasons or other reasons, to me, it makes me worried to start treatment on somebody who you're not going to be able to monitor in any way. I think for me that's also very highly associated with early stopping of treatment or discontinuation of treatment. The second thing is, in somebody who's got a family history of cirrhosis, that by itself doesn't meet any indicator for treatment. And there's a lot of different reasons. That family member may have developed cirrhosis in the context of never knowing they have Hep B because screening is still not widely adopted. And so I think that's a very different thing than the person you're dealing with in your practice themselves. If your patient has less than stage 2 liver disease and meets the other criteria, they can be kind of put into a watchful monitoring treatment category and don't need to be treated right now just because they have a family member have cirrhosis, because that family member may have other circumstances that led them to have cirrhosis, such as late diagnosis, not being on antiviral therapy, that may not really be applicable to the patient you are dealing with. And remember, once you start therapy, it's lifelong therapy. So you really want to commit the patients you really think need it to therapy. The third question was, if you have a first-degree relative with liver cancer, do you start the treatment do you initiate Hep B treatment independent of Hep B viral load? And, so I think this is one of those categories that, again, comes down to your discussion with the patient. Certainly, if they meet enough of the other categories, even independent of the viral load, you may want to go ahead and put them on antiviral treatment. This is where there's a gray zone. There isn't really a lot of guidance. My inclination in somebody who has a first-degree relative is to treat irrespective of the viral load, even though you won't find that exactly laid out in the guidances. And then I don't know what I forgot what your fourth question was as we were going. So if you remember it and you can let me know, that would be great.
Yeah, the first question was the presence of non-alcoholic steatohepatitis or non-alcoholic fatty liver disease or other risk factors in the presence of hepatitis B. Do you still use the same cutoff for treatment?
So I'll say, technically speaking, the guidances don't really give us a lot of, doesn't give us a lot of information or guidance in this area. So what to do when you have somebody basically with another competing variable that might accelerate their progression or increase the risk of fibrosis or liver cancer. My inclination is to have even a lower threshold to initiate treatment on these patients. But again, one thing, if you have readily available to do that could actually allow you to not initiate treatment so soon would be to, if you can reliably assess the fibrosis progression over time, that could really help guide you to see who is going to need this treatment, even if they have fatty liver compounded. So for example, if I do a FibroScan and somebody has a low steatosis score as well as low fibrosis score, but I did an ultrasound, I know they have fatty liver as well. Remember, not all fatty liver progresses into cirrhosis or fibrosis. It's really people who have steatohepatitis. And an ultrasound doesn't tell me who has steatosis and who has steatohepatitis. So, you know, not everybody with fatty liver disease is going to progress. Not everybody with fatty liver and Hep B, it's going to be really a compounded variable that's going to result in accelerated fibrosis progression. But the tricky part here is we don't really have good ways to tease out who's got steatohepatitis non-invasively. In these patients, considering a biopsy is something you could do to help kind of help you figure out to see who has steatohepatitis. And if you have established steatohepatitis, then my threshold might be lower. But outside of that, I would really use the fibrosis assessment and doing it more frequently, at least once a year, to see who might be progressing, developing F2 or higher, to say this person needs treatment now would be, to me, a sensible strategy to offer to the patient.
Sorry, I just want to quickly ask, sorry, at what FibroScan score do you consider starting treatment? At what FibroScan score?
So I think I included it in the slide set from last week or the week
I missed
before.
That, sorry.
No, it's okay, but it gives you the various cutoffs. So the FibroScan score for Hep B is typically between, I don't remember it actually off the top of my head because I use the FibroScan for Hep C and for a lot of other liver diseases. But I can send you that slide, and F2 and higher on that score would result. So I think patients, the case you submitted was somebody with a FibroScan score of like 7.4, and that person met F2 or higher, and so that made sense clinically why treatment was initiated.
Okay, thank you very much.
Yep, no problem.
Great, thank you for that. Ponni, there are a couple more raised hands. I do want to be mindful of everyone's time, though. Do you have any way you might like to field one more, and then we can email you?
I can do one quick question, and then, yeah.
Okay, great. I know the next raised hand before that was Mr. Diallo. So, Mr. Diallo, you're unmuted now. You should be able to ask your question.
Yeah, thank you. I apologize. I'm from a French-speaking country. My English is not very good.
Not a problem.
The upper limit of ALT for ISLD is higher than European guidelines. Why? Do you think it is for NAFLD or not? And the second question.
It's unclear because it's based on healthy volunteers, the data that the ASLD uses. So the normal range of an ALT value for a man is 29 to 33 based on the studies done here. So I do definitely think we have higher rates of obesity and diabetes and other things that could contribute. So I think it would just be kind of somewhat guessing as to the reasons. But the healthy volunteer range is, so those cutoffs are based on the healthy volunteer range, and it's 29 to 33 in men, that healthy volunteer ALT range, and in women it's a little bit lower. So the cutoffs are picked at kind of the upper limit or just above the upper limit of those healthy volunteers. Yeah.
Okay. Just a second question.
Yeah.
In my country, we have 90% of negative antigen, and for the evaluation of liver fibrosis, do you prefer for this kind of patient non-invasive test or FibroScan?
Well, FibroScan is a non-invasive test. So I think it depends on what you have readily available. In our setting, we do FibroScans quite often on these patients. It takes 5 minutes or less to do in the office. We get the results right away. And I can counsel the patient right there. So because of availability, we tend to do FibroScan. And I don't do it more often than once a year. Sometimes I might repeat it on another visit if I think that the patient just ate within the last 2 hours, or there's some other factor that might lead me to believe that the score was not an accurate score.
And what do you think about liver biopsy in this patient?
Yeah, so, I think liver biopsy, depending on where you practice and what you have available, is something to seriously consider. When I was training, all we had was liver biopsy. Even these FIB4 and OPRI scores were not very well developed. They've been more well fine-tuned, I think, for Hep C and NAFLD than for something like Hep B as well. So we had to think about, when do we think about doing a liver biopsy? And it was typically when somebody had a raised ALT, or a fluctuation or persistent ALT. And even then, sometimes we would do the biopsy and they wouldn't have much fibrosis. So then the question is, if the ALT remains kind of persistently in the same range, how do you do another fibrosis assessment if you don't have access to a FibroScan or some other non-invasive marker test? And in those settings, we would usually wait at least 2 to 5 years to do another biopsy because, you know, kind of our hallmark of thinking of fibrosis progression for the average patient with a liver disease is that it takes about a decade to develop, you know, one stage of fibrosis. Now, there are a lot of things that can change that. If you have a HIV infection, you have fatty liver with steatohepatitis, if you have other things that might put you at risk. So it's not it wasn't an exact, but 2 to 5 years was kind of our thinking in terms of when would be the time period to even think about repeating another biopsy. Because we feel a little stuck in somebody where you do the biopsy and you have F0 to 1 disease and their ALT is elevated, right? Like when will we pick up additional fibrosis being developed? So that 2 to 5 years is what we used to use. As I said, in my clinical practice, I hardly ever do a liver biopsy now because we really rely on things like a FibroScan to help guide us.